Hello everyone, welcome back to the channel. Today in this video we will be covering the examination part of the inguinal hernia. Before watching this video, if you didn't watch the history taking of the hernia, I will recommend you to watch that first, then watch this lecture for more clarity of the concepts. Okay, let's start the lecture. We will ask the patient for the consent to touch him for general examination. Patient is conscious oriented. We will not mention cooperative here because he is cooperative, that's why he gave the history. There is no pallor, no icterus, no cyanosis, no clubbing, no pedal edema, no generalized lymphadenopathy. Vitals, afebrile, pulse 78 per minute. Here no need to mention about the rate, rhythm, volume, special characters, as this is more significant in the medicine history. Respiratory rate 17 per minute. Abdominothoracic type, blood pressure 120/80 mm of mercury, measured in the right upper limb in the sitting position. Local examination of the inguinoscrotal region. After getting consent from the patient, he is exposed from umbilicus to mid-thigh and examined in the standing position. In inspection, we have to check the shape, size, extent of the swelling. A single spherical shaped swelling, size approximately 8 x 6 cm in inguinoscrotal region, extending above downwards from the groin crease up to the root of scrotum. Surface appears to be smooth. Well-defined margins are present. Skin over swelling is normal. In case of strangulated hernia, the skin over the swelling appears to be red. Cuff impulse present on cuffing. Whether the swelling becomes more prominent or not, we have to check. Reduces spontaneously on lying down. It indicates a direct hernia. If we have to reduce the swelling with our own fingers, it will indicate indirect hernia. No visible peristalsis is present. No scars, sinuses, dilated veins over the swelling. If the sinus is present, it will indicate enlarged lymph nodes containing pus. Due to draining of the pus, it will form sinus. Palpation, no warmthness, no tenderness. Inspectory findings are confirmed like site, size, shape and surface by palpation. Site inguinoscrotal region, size 8 x 6 cm. Shape spherical in shape. Extension, we have to mention 3 borders. Lateral border 7 cm from anterior superior iliac spine. Medial border above and medial to pubic tubercle. Inferior border above the root of the scrotum. Expansile cuff impulse present. In normal cuff, the fingers moves forward and backward, whereas in expansile cuff means when we keep the fingers over the swelling after reducing it either manually or through lying down and tell the patient to cuff, the mass is felt which expands the finger apart. The swelling is elastic in consistency. Consistency tells about the content in the sac. Consistency, if it is doughy or granular. Granular will feels like mustard seed. It will tells about the content is omentum. It will call as omentocele. And if consistency is elastic, the content is intestine and we will tell it as enterocele. It is not possible to get above the swelling. Differentiate between hernia swelling from pure scrotal swelling. In hernia, it's not possible to get above the swelling. How to demonstrate get over the swelling? For this, we have to held the root of the scrotum, which is the part from where scrotum are attached. Root of the scrotum is this. We have to hold in such a way so that thumb will be in front and fingers are at back. If you feel the swelling, it is scrotal swelling, not hernia swelling. Skin over the swelling is normal. Both the testes separately palpable. This we will not include in palpation part. We will keep this in the examination of external genitalia. Not enlarged lymph nodes on the both sides. Zeeman 3-finger test. Before going to this test, we have to first know the landmarks of the superficial inguinal ring, deep inguinal ring and inguinal ligament. From anterior superior iliac spine to pubic symphysis, we have to draw one line. Midpoint between the anterior superior iliac spine and pubic symphysis is mid-inguinal point. This one is mid-inguinal point. Half inch above to the mid-inguinal point is deep inguinal ring. Mid-inguinal point and midpoint of inguinal ligaments are different. Mid-inguinal point is point between anterior superior iliac spine and pubic symphysis, whereas midpoint of inguinal ligament is point between anterior superior iliac spine and pubic tubercle. For making inguinal ligament, the attachment is anterior superior iliac spine to pubic tubercle. Superficial inguinal ring, it is a triangular opening which is above and lateral to the pubic tubercle. Superficial inguinal ring is present in the Hazelbeck triangle. So let's see the boundaries of Hazelbeck triangle. Medially, it is bounded by lateral border of rectus abdominis muscle, laterally by inferior epigastric vessels, and inferiorly by inguinal ligament. Saphenous opening is 4 cm below and lateral to the pubic tubercle. After knowing all the landmarks, we will proceed with the Siemens 3-finger test. In Siemens 3-finger test, we have to place 3 fingers. First finger is index finger on the deep inguinal ring, second finger, which is middle finger, on the superficial inguinal ring, and third ring finger on the saphenous opening. After reducing the swelling, we have to place our 3 fingers on the swelling and we have to tell the patient to cough. If the impulse felt on the middle finger, it will indicate a direct hernia. If the impulse felt on the index finger, it will indicate direct hernia. If the impulse is felt on the ring finger, then it will direct as femoral hernia. Deep ring occlusion test. It is the confirmatory test for indirect and direct hernia. In deep ring occlusion test, we have to keep our thumb on the deep inguinal ring, which is ½ inch above the midpoint between ASIS and pubic symphysis. After reducing the swelling, we have to occlude the deep inguinal ring with the thumb and we have to tell the patient to cough again. On coughing, if the swelling appears medial to the thumb, it will tell about the direct hernia. If on coughing, swelling didn't appear, it will tell about the indirect hernia. We will not perform finger invagination test to prevent the pain to the patient. On percussion of the swelling, if resonant note is heard, then it denotes intestine. If the dull note comes, then it will indicate it contains omentum or extraperitoneal fatty tissue. If on auscultation bowel sounds are heard over the swelling, it will indicate enterous seal. Examination of external genitalia. Penis is in midline. If the swelling is very large, penis is pushed away from the swelling. No phimosis. Phimosis is inability to retract the foreskin. Urethral meatus appears normal. There is no stricture in the urethra. Scrotum appears normal. Testis is palpated separately. Examination of tone of the abdominal muscle. No Malgagny's bulging is seen. Malgagny's bulging are oval-shaped bilateral bulge parallel to the medial half of the inguinal ligament when patient is asked to lift body or head against the resistance which we apply. This is Malgagny's bulging, which is in the lie down position against the resistance. Examination of left inguinal region. There is no swelling present. Other system examination. Abdomen examination. Soft, non-tender, no free fluid is present, no organomegaly. Respiratory system. Normal vesicular breath sounds heard all over the areas, no added sounds. Cardiovascular system. First heart sound and second heart sound heard. Don't mention S1 and S2 heard. No murmurs. Central nervous system, no focal neurological deficit. Summary: a 52-year-old man, cattle rearer by occupation, non-smoker, non-alcoholic, not a known case of diabetes mellitus, TB, hypertension, CAD, asthma or COPD, presented with reducible swelling in the right groin for past 4 days, which increases on coughing and straining, decreases on lying down, disappears on manipulation, not associated with pain, no history of constipation, abdominal distension, vomiting, chronic cough. On examination, a spherical shaped, non-tender, reducible, right-sided inguinoscrotal swelling is present, which lies above and medial to pubic tubercle, with expansile cuff impulse and Siemens 3-finger and deep ring occlusion test positive for direct inguinal hernia. Provisional diagnosis: a case of right-sided incomplete reducible direct inguinoscrotal hernia with probably intestine as its content. Investigations for hernia. For assessment of the patient, USG abdomen and pelvis is done. Routine investigation, complete blood count, blood sugar, urine sugar, albumin deposits, RFT, LFT, chest X-ray, ECG, HIV, HBS antigen test is done. Treatment, Lichtenstein tension-free hernioplasty is done. Hope you like the video. Thank you for watching.